Okay, so we pick up here with a discussion of endocarditis, which is an inflammation of the endocardium, and this can come about as a result of infection of the valves of the heart, the mitral valve, the aortic valve, as well as the inner lining of the heart. Two variations have distinct groups of causative agents. There's acute and subacute. Surgical innovation of prosthetic valves presents a hazard for endocarditis because bacteria can be introduced during surgery and the valves serve as infection sites. What do we see? For both acute and subacute, we see fever, fatigue, joint pain, edema of the extremities, weakness, anemia, abnormal heartbeat. Symptoms of subacute endocarditis develop slow and are less pronounced than those in the acute condition. Abdominal or side pain is reported. The patient may look ill and have petechia over half of the body and under their fingernails. Now, what are petechia? Petechia are tiny little, they look like blood splotches, but what they are actually ruptured capillaries. Janeway lesions are red painless spots on the palms and the soles. Osler's nodes are small painful nodes on the pads of the fingers and toes. Subacute cases may have enlarged spleen that developed over time. Cases of extremely long duration can lead to clubbed fingers and toes due to lack of oxygen in the blood. So here you can see what a healthy and an unhealthy valve looks like. Now, again, you're going to see a problem with cardiac output because the valves aren't going to be able to shut the way that they're supposed to. The result is that you're going to pick up heart murmur as well. They'll form little things called vegetations on the valves. Acute endocarditis is most often the result of an overwhelming blood challenge with bacteria. These bacteria can produce vegetations, and this can hamper the function of the heart valve and even lead to death. Also, pieces of these vegetations can break off, forming emboli that can block blood supply to vital organs. They're a constant source of blood-borne bacteria as well, so these colonies are bad news. It's most often caused by Staph aureus, as well as Strep pyogenes, Strep pneumonia, Neisseria gonorrhoeae, and other bacteria. It can be transmitted parenterally through direct entry into the body. IV and sub-Q drug users have been a growing risk for this condition. Traumatic injuries and surgical procedures can also introduce a large number of bacteria. Subacute is almost always preceded by some form of damage to the heart valves or by congenital malformation. Irregularities in the valves encourage the attachment of bacteria, which form biofilms and impede normal function. This provides an ongoing source of bacteria into the blood. People who've suffered rheumatic fever and damage to the heart valves are susceptible to this condition. Causative agents, usually bacteria of low pathogenicity originating in the oral cavity. Alpha hemolytic strep, such as strep sanguinis or oralis or mutans, can be causative agents. Normal biota from the skin and other bacteria can colonize abnormal valves and lead to subacute endocarditis. What causes it? Minor disruptions in the skin or mucous membrane to introduce bacteria in the blood. This can come from rigorous toothbrushing or dental procedures or minor cuts and lacerations. The bacteria aren't transmitted from other people or the environment. How do we prevent? Prophylactic antibiotic therapy in advance of surgical and dental procedures. Now, septicemia occurs when pathogens enter the bloodstream, specifically here bacteria and viruses. Patients suffering from this condition are called septic. Fever is a prominent feature. The patient is ill and has an altered mental state. We also see shaking, chills, and GI symptoms. Increased breathing rate is accompanied by respiratory alkalosis. Low blood pressure is a hallmark of this condition. This is caused by inflammatory response to the infection, leading to vasodilation. The result is that the blood pressure drops dramatically. The loss of fluid from the vasculature also reduces the blood pressure as well. This can result in death. There's a vast majority of these that are caused by bacteria. It's evenly split between gram-positives and negatives, but MRSA is a major cause. 10% are fungal. Polymicrobials are about a fairly significant portion of these infections. This occurs when more than one microbe has been identified as causing the septicemia. How about the virulence factors? Gram-negative bacteria multiplying in the blood, releasing endotoxin. Stimulates massive inflammatory response mediated by cytokines. This leads to a drastic drop in blood pressure known as endotoxic shock. Gram-positives can instigate a similar cascade of events when fragments of the cell wall are released into the blood. How do we transmit? It can be traced to parenteral introduction of microbes by IV lines or surgery. Other infections can come from UTIs, renal, prostatic, pancreatic, or gallbladder abscess. Patients with underlying spleen malfunction can be predisposed to multiplication of the microbes in the blood. Meningitis or pneumonia occasionally lead to sepsis. Remember that the spleen is the counterpart to the lymph node for the bloodstream. It's tasked with removing pathogens directly from the blood. Approximately 500,000 cases annually in the U.S., resulting in over 100,000 deaths. Since the infection's in the blood culture is the obvious diagnosis. A full regimen of media is inoculated to ensure isolation of the organism responsible. Antibiotic susceptibilities are checked with Kirby-Bauer. Empiric therapy should be started immediately before culture and susceptibility results come online. How do we prevent? Broad-spec antibiotics. The treatment should be adjusted after the organism is identified and susceptibilities are known. Okay, plague. You've probably heard of bubonic plague. This is a pandemic. Okay, it's been a pandemic throughout history. It's occurred since biblical times. The first reliably chronicled plague killed an estimated 100 million people in the 6th century A.D. Examples include pneumonic plague, which is a respiratory disease we've already discussed, and bubonic, which is a bacteria injected by a flea bite entering the lymph and filtered by the local lymph nodes. The infection causes inflammation and necrosis of the node. This results in swollen lesions called a bubo, usually in the groin or the axilla. The incubation is 2 to 8 days, ending with chills and fever, headache, nausea, weakness, tenderness of the bubo. Mortality rates are about 15%. Septicemic plague. Pneumonic and bubonic can both progress to infection of the blood. Presence of bacteria in the blood results in disseminated intravascular coagulation, subcutaneous hemorrhage, and purpura, which degenerates into necrosis and gangrene. Basically, you generate blood clots all over the body in areas where they're not necessarily needed, and paradoxically, that leads to an increase in the likelihood of bleeding and bruising. Mortality rates, once the disease gets to this point, are close to 50% with treatment and 100% without. Because of the visible darkening of the skin, the plague has often been called the Black Death. The causative agent is Yersinia pestis, which is a gram-negative rod, a member of Enterobacteriaceae. It displays unusual bipolar staining that makes it look like a safety pin. The number of bacteria required to initiate is between 3 and 50 cells, so this is relatively potent. Transmission. Fleas are the principal agent. After a flea ingests a blood meal from an infected animal, the bacteria multiply in the gut. The flea esophagus gets blocked due to coagulation factors produced by the pathogen. Unable to feed, the flea jumps from animal to get nourishment, and during this process, regurgitated infectious material is inoculated into the bite wound. The distribution of the plague is extensive. The incidence of the disease has been reduced in the developed world, although it's increasing in third world countries. It is endemic in the U.S. and western and southwestern states. Persons at risk for developing plague include vets and people living and working. Signs and symptoms of tularemia has an incubation period of a few days to 3 weeks. We see backache, chills, fever, malaise, weakness. We also see ulcerative skin lesions, swollen lymph glands, conjunctival inflammation, sore throat, GI disruption, and pulmonary involvement. Death rates are up to 30%. The causative agent is Francisella tularensis, a facultative intracellular gram-negative bacteria, which means that it's generally found inside the cells but can also grow outside them. It has several characteristics in common with Yersinia pestis. Both were grouped in the genus Pasteurella. It's a zoonotic disease of assorted animals endemic to the northern hemisphere. Thus, it's been called rabbit fever. It's currently listed as a pathogen of concern on bioterrorism lists. How is it transmitted? Rabbits and rodents, which include muskrats and ground squirrels, are the chief reservoirs. We also see it in skunks, beavers, foxes, possums, and some domestic animals. The chief route of transmission has been through skinning rabbits. With the decline of rabbit hunting, the transmission through tick bites is more common. Ticks are the most frequent arthropod vectors, followed by biting flies, mites, and mosquitoes. The infective dose is around 20 organisms. Tularensis is considered the most infectious of all of the agents of tularemia. Cases have appeared in people who've accidentally run over dead rabbits while lawn mowing. Presumably they inhaled aerosolized bacteria. In 2009, 2 people in Alaska acquired tularemia by wrestling infected rabbits from their dogs' mouths. How do we prevent? Intracellular persistence of tularensis can lead to relapse. Antimicrobial chemotherapy must not be discontinued too early. Protection is available in the form of a live attenuated vaccine. Lab workers and other occupationally exposed personnel have to wear gloves, masks, and eyewear. Okay, here's a bit on Lyme disease.
There are 3 possible ways for Lyme disease to be transmitted. Number 1, by the bite of an insect or tick that transfers blood. 2, in a pregnant woman, from the mother to the fetus via the placenta. And 3, sexually transmitted. Lyme also contains co-infections such as Babesia, Ehrlichia, Bartonella, and secondary infections such as Mycoplasma, Candida, and viruses as HHV6, cytomegalovirus, and Epstein-Barr. Lyme is characterized by a spirochete infection. The spirochete releases bacterial lipoproteins, that is a neurotoxin. The BLP neurotoxins are associated with symptoms like memory problems, burning and neurological pain, and numbness. The spirochete moves in a corkscrew-like motion as it burrows its way through the tissue and organs of the body. The spirochete contains antigens, and the antigens are like fingerprints, which identify this infection to the body's immune system. The dendritic cell is a key part of the immune system. One of the major functions of the dendritic cell is to process the antigen and present it to other parts of the immune system. This is why the dendritic cell is called the antigen-presenting cell. Once the spirochete enters the human body, it comes into contact with the dendritic cell of the immune system. The spirochete rubs or displaces the antigens onto the dendritic cell. Then, the dendritic cell begins to process the antigen of Lyme disease for the other parts of the immune system to recognize it. The helper T cells come along and pick up the processed antigen off of the dendritic cell. Then, the helper T cells proceed to pass the antigens along to another portion of the immune system called the killer T cells. The job of the killer T cell is to hunt down the spirochete infection and eliminate it by using the antigens to identify the Lyme disease. As the spirochete burrows into the body, it continues to spread its antigen onto the surface of healthy tissue and organs. The killer T cells follow as they seek out the antigen of the spirochete. In this process, the killer T cells begin to destroy healthy tissues and organs because they cannot differentiate between the antigen of the spirochete or the antigen of healthy tissue. As the killer T cells come into contact with the antigen located on the healthy tissue, we begin to see inflammation and destruction of the healthy tissue. This is clearly seen in autoimmune disease process, where the immune system cannot distinguish between self and non-self. As the spirochete is continuously moving, it's releasing the BLPs, the bacterial lipoprotein, which is impairing the immune system and causing inflammation, irritation, and damage to the peripheral and central nervous systems. The problem remains. The number of cases of Lyme disease reported to the CDC do not represent the total number of cases that exist. Lyme disease, its co-infections, and secondary infections may represent more than 300 different medical conditions, such as chronic fatigue, fibromyalgia, and other autoimmune diseases. The following diagram is designed to help explain the various scenarios of chronic Lyme disease treatment. There are three major focal points in the treatment of Lyme disease. One, the disease itself, which is represented by Lyme, its co-infections, and secondary infections. Two, the immune system, such as CD57 and other immune modulators. And three, the neurotoxins, or the bacterial lipoproteins in yellow, that usually take a longer time to clear up as the infection improves. As the immune system increases and the infection decreases over time, which is represented in the yellow line, we see the windows of symptoms improving. Also notice that it takes the bacterial lipoprotein neurotoxins longer to clear. This represents the ideal course of treatment. Unfortunately, this does not occur in the current methods of treatment. Now, let's review three common treatment scenarios. Number one, the patient is diagnosed with Lyme disease and then given 4 to 6 weeks of IV antibiotics. You'll notice it does nothing for the immune system except impair immune function. Slightly shifting the disease over 4 to 6 weeks, and then you'll see the relapse once the antibiotic treatment ends. You'll notice the antibiotics do nothing to address the co-infections, the secondary infections, or the neurotoxins related to the Lyme disease, and it does nothing to strengthen the immune system. In the second scenario, you'll see the patient is using IV antibiotics, dietary herbs, and supplements. The IV antibiotics bring the infection down a little bit, and the dietary herbs and supplements slightly increase the immune system. As in the first example, once the patient stops therapy, we see another relapse. The third scenario represents a patient using advanced immunotherapy. Notice the sharp increase and rise in the immune system. In addition to the IV antibiotics used to treat the infection, you'll see aggressive natural antiviral, antifungal treatments to fight the infection, and you'll notice a sharp decrease in the elimination of the infection. And finally, notice biodetoxification that is used to help the neurotoxin and the bacterial lipoproteins to be facilitated out of the body. This represents the Invita advantage in utilizing a comprehensive treatment plan to treat Lyme disease.
Again, the causative agent, Borrelia burgdorferi. Most common mode of transmission, biological vectors. The virulence factors include antigenic shifts and adhesins. We can culture and diagnose using PCR and ELISA. We prevent by avoiding tick bites. The treatment, antibiotics, cephalosporin, amoxicillin, penicillin. It's endemic to North America, Europe, and Asia. 300,000 cases a year in the U.S. with only 10% reported. Here's infectious mono.
Hello, today I'm going to talk about glandular fever. It's basically an infection caused by a virus, the Epstein-Barr virus. It is sometimes known as the kissing disease because the virus can be passed on via saliva. Coughs and sneezes and sharing food utensils can also pass it on. It's harder to catch than a cold. It generally affects teenagers and younger people. A full and quick recovery without the need to see a doctor is the usual course of events. Some can carry the virus in their body without developing infection. This is harmless. Normally, it's not possible to work out who gave the infection to whom. Symptoms begin between 4 and 8 weeks after infection and start with a very severe sore throat. Swollen tonsils, a high temperature and difficulty swallowing. Other symptoms include tiredness and poor appetite, muscle aches and headaches, swollen tender glands in the neck and armpits, skin rash, sometimes associated with antibiotics, abdominal pain. No response to antibiotics makes glandular fever more likely. Glandular fever is very difficult to diagnose from other causes of sore throats and tonsillitis. In most cases, this does not matter as symptoms will resolve quickly. Glandular fever symptoms are unlikely to improve with antibiotics. Antibiotics don't work for viral infections. Most sore throats need no investigation. If, however, after a trial of antibiotics your symptoms fail to resolve, your doctor may decide to take a blood test. These can confirm whether glandular fever is present and look for other infective causes. Still, no treatment will be possible, but at least you will have a better idea of what to expect. If you have glandular fever, your doctor will advise measures to help improve your symptoms by reducing your fever and ensuring plenty of fluids are drunk. Avoidance of alcohol is helpful. Like most infections, symptoms can range from mild to severe, but you should feel better in a week or so. Unfortunately, in some cases, glandular fever can be extremely severe. This is rare. Some people experience fatigue and low mood for weeks after initial symptoms have subsided. This is not so rare. Most cases of sore throat are not glandular fever. Consult your doctor if symptoms are persistent or if you are significantly unwell, have great difficulty swallowing, or you have abdominal pain.
Again, causative organism, Epstein-Barr virus. Most common mode of transmission, direct or indirect contact with infected fluid. It is latent, has the ability to incorporate into host DNA and live with the host throughout its life. Diagnosis is a differential, and we can also do a monospot test for specific antibody using ELISA. The treatment is supportive. It's common in teens, about 500 to 100,000 cases annually. Hemorrhagic fever. It's a number of agents that infect the blood and lymphatics, causing extreme fever, some of which are accompanied by internal hemorrhage. The presence of virus in the blood causes capillary fragility, disrupting blood clotting and leading to degrees of pathology, including death. All viruses causing hemorrhagic fever are RNA-enveloped viruses, and the distribution of the virus is restricted to their natural host distribution. So these viruses likely would have reverse transcriptase somewhere in the replication cycle. Examples: Ebola in 2014 was outpacing efforts to control it, revealing weaknesses in public health administration for a swiftly spreading contagion. Chikungunya was never before transmitted to the Americas It was locally transmitted by mosquitoes in the U.S. and Central America. Yellow fever is endemic to Africa and South America, more frequent in rainy climates, carried by the Aedes aegypti mosquito. Dengue fever is endemic to the Southeast Asia and Indian continents. Epidemics have occurred in South America, Central America, and the Caribbean, and is carried again by Aedes aegypti mosquitoes. Chikungunya is an endemic to Africa but has appeared in Western Europe, carried again by Aedes aegypti mosquitoes. Ebola is endemic to Africa, causing capillary fragility and causing the patients to basically bleed out of their open areas and through their mucous membranes. Bats are thought to be the natural reservoir for Ebola. Lassa fever is endemic to West Africa. It's asymptomatic in 80% of cases, and in others we see severe symptoms. The reservoir is the multi-mammate rat. And here you can see the rundown on the different hemorrhagic fevers. Again, all characterized by the production of massive loss of blood as a result of damage to soft tissue as a result of the vector's growth. Non-hemorrhagic fever. These are infectious diseases that result in a syndrome characterized by high fever but without capillary fragility that leads to the hemorrhagic symptoms. They're all caused by bacteria. Example is brucellosis, also known as Malta or undulant fever or Bang's disease. Causes outbreaks of placental infections in livestock. It's listed as a possible bioterror agent. Signs and symptoms: when it's caused by brucella, they live in phagocytic cells, carrying the bacteria to the blood and creating focal lesions in the liver, spleen, bone marrow, and kidney. Cardinal manifestation is a fluctuating pattern of fever. It's the origin of the name undulant fever. Causative agent is brucella, which are tiny aerobic gram-negative coccobacilli, Brucella melitensins, Brucella abortus, and Brucella suis can cause the disease in humans. The principal manifestation of the disease in animals is an infection of the placenta in the fetus. Human placentas do not become infected. Q fever is the name of the disease caused from the frustration of not being able to identify its cause. Q stands for query. It's caused by Coxiella burnetii, identified in the mid-1900s. We see abrupt onset of fever, chills, head and muscle aches, and occasionally rash. The disease sometimes is complicated by pneumonia. In 30% of cases, we also see hepatitis and endocarditis. A quarter of the cases are chronic rather than acute and result in vascular damage and endocarditis-like symptoms. The causative agent, Coxiella burnetii, is a small pleomorphic gram-negative bacteria. For a time it was considered a rickettsia. It is an intracellular parasite resistant to environmental pressures by forming an endospore-like structure. How is it transmitted? It's harbored in a wide assortment of vertebrates and arthropods. The ticks are important in transmission between wild and domestic animals, but they don't transmit the disease to humans. They acquire the infection by means of environmental contamination and airborne spread. Birth products like the placenta of domesticated animals contain large numbers of bacteria. Other sources include urine, feces, milk, and airborne particles from infected animals. People at high risk are farm workers, meat cutters, vets, lab techs, and consumers of raw milk. How do we prevent? Subclinical cases will resolve. More severe cases respond to doxycycline. A vaccine is also available, but not in the U.S. Cat scratch disease begins 1 to 2 weeks after being clawed by a cat. You see a cluster of small papules at the site of inoculation. Most infections remain localized and resolve in a few weeks. The causative agent is Bartonella henselae. It's a small gram-negative rod. It is fastidious, but not an obligate intracellular parasite, so it will grow on blood agar. The pathogen is present in over 40% of cats, especially kittens. 25,000 cases annually in the U.S., 80% are children between 2 and 14. Prevention: azithromycin, erythromycin, rifampin. Disease can be prevented by antiseptic cleaning of the cat bite or the scratch. Here's Rocky Mountain spotted fever.
Good afternoon and welcome to today's brief discussion concerning the disease Rocky Mountain spotted fever. What I hope to accomplish is to increase your basic understanding of the disease, how it is diagnosed, treated, and prevented. Rocky Mountain spotted fever, according to the Center for Disease Control, is the most severe tick-borne rickettsial illness in the United States. This disease is caused by the intracellular bacteria Rickettsia rickettsii, a delightfully redundant name. We'll call him Rick from now on. Rocky Mountain spotted fever is considered a seasonal illness, as around 90% of all cases are reported between the months of April and September each year. Contrary to its name, Rocky Mountain spotted fever is most common in North Carolina and Oklahoma, which compose 35% of yearly cases. The entire Rocky Mountain region, however, only contains 3% of cases. Between 800 and 1,200 cases are reported each year in the United States. This figure makes the previous statements even more apparent. You can clearly see the concentration of cases in a thick belt between Oklahoma and North Carolina, with Oklahoma and North Carolina carrying the most concentrated areas. Additional patterns that have shown up over the years is that the most common people to be infected are Caucasian males and children. In fact, 2/3 of reported cases of RMSF occur in children ranging from 5 to 9 years old. It's also been shown that people that spend extensive time around dogs are more likely to get the disease at least once, since they carry the most common vector for the disease. So by now you're probably wondering why it's called Rocky Mountain spotted fever in the first place if it's rare in the Rockies. And for that we're turning our attention to Howard Ricketts. Howard was a pathologist working for the University of Chicago when he became interested in RMSF after hearing about its discovery in 1896. He and a research team not only managed to isolate the responsible organism, but also its vector. This was in 1900. Unfortunately, Howard died a mere 10 years later in Mexico City after isolating the organism behind typhus, which is another rickettsial illness. He was killed by the organism he isolated. The organism behind RMSF is named in his honor. Now that we know a little bit more about our little friend's history, let's take a look at some of its general attributes. It is an obligate, intracellular, gram-negative bacteria that is non-motile and highly pleomorphic. It is able to take on the form of rods, cocci, and long strand-like threads based on its environment. It relies on eukaryotic cytoplasm for replication, and its home of choice is the endothelium of small to medium-sized blood vessels. In order to infect vertebrate hosts, it uses a vector in the form of a tick. The two most common ticks that act as vectors are the American dog tick and the Rocky Mountain wood tick. The life cycle of our tiny assailant is extremely convoluted, but it mostly looks something like this. Infected tick bites vertebrate host, an uninfected tick bites the infected host, the uninfected tick becomes infected. If the tick is male, it infects a female through mating. If the tick is female, it lays eggs containing infected larvae, which hatch into infected ticks, and the cycle starts over again. After entering the body through a tick bite, our friend Rick sets up shop. As stated earlier, he prefers small to medium-sized blood vessels if he can get them. Once inside a host cell, Rick replicates inside the cytoplasm or inside the nucleus, causing cellular damage. This leads to microscopic damage to the vessels, allowing tiny amounts of blood to escape. This escaping blood leads to the characteristic rash that is common in RMSF victims. This cellular damage can also directly damage organs. As far as signs and symptoms go, there are several. Initial symptoms include fever, nausea, vomiting, muscle pain, lack of appetite, severe headache. Later signs and symptoms include rash, abdominal pain, joint pain, and diarrhea. In other words, you really don't feel well. You're not a happy camper. There are also several ocular signs and symptoms, such as petechial conjunctivitis, anterior uveitis, retinal hemorrhages, cotton wool spots, retinal vascular engorgement, tortuosity, branch retinal arteriolar occlusion, and optic disc edema. As you can see, these signs are just as numerous as they are varied, and as a result, you will probably not be able to make a diagnosis directly from these ocular findings. Diagnosis comes chiefly from symptoms and history, as there is no fast lab test for diagnosing RMSF. Lab tests are usually done for confirmational purposes only. Physicians instead rely on the classic triad of fever, rash, and history of tick bite to determine if treatment for RMSF is necessary. If the patient gets better, it was probably RMSF. If they want to confirm their diagnosis, they look for thrombocytopenia, hyponatremia, elevated liver enzyme levels, and a positive indirect immunofluorescence assay. The IFA is the reference standard for identifying RMSF. If the disease goes untreated, you're in a heap of trouble. RMSF has a 30% mortality rate if no action is taken, and a 71% hospitalization rate even if action is taken. RMSF can wreak havoc on your internal body systems, causing things such as gangrene, pulmonary hemorrhage, myeloencephalitis, and myocarditis. The good news is that RMSF is very treatable. Almost every case responds against doxycycline, the drug of choice. If doxycycline isn't an option, chloramphenicol is used instead. Of course, the best way to fight against the disease is to not catch it at all. The most effective yet most extreme method is to not go outside between April and September. A slightly more attractive option is simply to wear lightly colored clothing so the ticks show up better. You should also check yourself thoroughly after being outside in an area where you are likely to pick up ticks. The best course of action as far as clothes are concerned is to tuck your pants into your socks to prevent ticks from climbing up your legs. And although that sounds both hot and silly looking, consider this a possible alternative. Anyway, it's also good to spray your shoes and clothing with permethrin, which can last for days if you're out camping. Use spray containing DEET on your skin, but be careful, DEET only lasts for a few hours. Also be careful using DEET on children, as it is known to cause adverse effects in high amounts. Last but not least, if you see a tick on you, get it off as soon as possible. This brings us to a critical point on the proper removal of said tick. To properly remove a tick, you must grasp it as close to the skin as possible with fine-tipped tweezers. You must then pull up with even pressure. Avoid twisting, as this could cause the mouth to break off or the tick to regurgitate, increasing your chances of infection. After removing the tick, disinfect the area and wash your hands thoroughly. The CDC also recommends you place the tick in a plastic bag, date the bag, and then place the bag in your freezer in case you get sick. This would allow for a quicker and more accurate diagnosis of your illness. In conclusion, remember that prevention is a very powerful ally in defending yourself from RMSF. And if you have RMSF, the best course of action is to get it treated as soon as possible. If you would like to learn more about Rocky Mountain Spotted Fever, I highly recommend the Rocky Mountain Spotted Fever section on the Center for Disease Control website. Thank you for listening.
Here's the rundown of the non-hemorrhagic fever diseases, giving you, again, the causative agent, the virulence factors, the prevention, the treatment, the features, and the epidemiology. Here's Chagas disease.
Definition. Chagas disease, also known as trypanosomiasis, is an infectious inflammatory disease caused by a parasite found in the feces of the triatomine or reduvid bug, which is very common in Latin America and the southern United States as well. Symptoms. Symptoms pretty much range from mild and acute to severe, and patients usually do not detect symptoms till the disease hits a long-lasting chronic stage. Acute phase. This usually lasts for weeks or months, almost symptom-free. Typical but mild symptoms that may show up include the following. Fever. Swelling around the infection, eyelids and glands. Fatigue. Body ache and headache. Rashes. Loss of appetite. Nausea and vomiting. Diarrhea. Enlarged liver or spleen. Acute symptoms usually go away on their own, but in some cases, if left untreated, they advance to the chronic phase. Chronic phase. This phase may never show up or may show up 10 to 20 years after the first infection. Typical symptoms in severe cases include the following: irregular heartbeat, congestive heart failure and sudden cardiac arrest, abdominal pain or constipation due to enlarged colon, difficulty in swallowing food due to enlarged esophagus. Risk factors. This disease, most often diagnosed in children, can literally infect anyone. Living in structures built with mud, adobe or thatch in rural impoverished areas of Latin America where the triatomine bugs are rampant. Traveling to a high-risk area of Chagas disease. Blood transfusion or organ transplant from someone with Chagas infection. Diagnosis. The doctor will ask for the following: a physical examination to check signs and symptoms of the disease or any risk to the disease. Blood tests to confirm the presence of the disease in the bloodstream. Additional tests like ECG, chest and abdominal X-ray, echocardiogram and upper endoscopy to check the stage of the disease and the resultant complications. Treatment. Prevention of infection is always ideal. The first line of treatment is to kill the parasite in acute infection and then go about managing signs and symptoms in later stages. If left untreated, it can cause severe heart and digestive problems. Treatment for heart-related complications include medications, pacemaker or any support device to regulate the rhythm of the heart, surgery or a transplant. Treatment for digestive-related complications include a diet change, medications, corticosteroids and surgery in extreme cases. Medications during the acute phase may benefit the patient, though not so much in the chronic stage. The medications during the chronic stage don't cure disease but help slow the progression of the disease and complications that come with it.
And here's the rundown on Chagas. Here's anthrax.
Anthrax is an often fatal bacterial infection that results when the endospores of the bacteria are introduced into the body from one of three ways. One form of infection is initiated when the endospores enter through a cut or abrasion in the skin. This is known as cutaneous anthrax. Once inside the skin, the endospores migrate to the bloodstream. Another form of infection can result from the introduction of endospores into food, which is then consumed. This is known as gastrointestinal anthrax. Inhalation anthrax is the third form of infection and occurs when airborne endospores are inhaled into the body. After a brief journey to the lungs, the endospores enter alveolar sacs where they attach to the tissue of the alveoli. This is where the body initiates an immune response against the anthrax endospores. Immune cells in the body, called macrophage cells, become alert of the endospores' presence and begin to attack by exiting the bloodstream. The immune cells engulf the endospores as foreign bodies and then enter back into the bloodstream where they travel for a brief time. The normal response of macrophage cells is to destroy bacteria allowed to invade the body, then travel to lymph glands where they prepare the immune system for future attacks. However, anthrax endospores are not destroyed, but begin to germinate within the macrophage cells until they end their journey within a lymph gland. Once inside the gland, the endospores develop into vegetative bacteria known as bacilli, which are then released from the macrophage. Once released, the bacilli cause damage to the cells of the lymph gland and begin to travel throughout the lymphatic system. During their travel, the anthrax bacteria begin to grow and multiply, infecting surrounding areas where they eventually make their way back into the bloodstream. Also during their travel, the anthrax bacteria emit virulence factors which contain the exotoxins responsible for a condition known as toxemia or blood poisoning. The exotoxins are then released from the bloodstream where they invade neighboring cells. This invasion makes the cells unable to regulate their environment and causes the cells to release water and eventually die. This buildup of water causes a condition known as pulmonary edema, in which a large amount of fluid accumulates in the lungs, resulting in tissue damage and pulmonary complications. For most people, symptoms can occur between 1 and 7 days from exposure to the anthrax bacteria. Such symptoms resemble a common cold and may include fever, cough, chills, muscle pain, shortness of breath, and shock. Inhalation anthrax, if not treated, can progress to severe disease and is usually fatal.
And here's the summary of the circulatory diseases and the pathogens that infect different parts of the circulatory system and what they are, whether they're bacteria, virus, fungus, etc. Okay, see everybody in the next podcast. Thanks for listening.